Very good evening, one and all. Very good evening, seniors, juniors, ladies and gentlemen, as well as fellow doctors. So, we all have gathered here for an academic feast to follow. As we all know, certain conferences were just over, uh, uh, just got completed in Europe, wherein a lot of updates for diabetes were discussed. And as we all know from our clinical practice, diabetes is a huge burden here in India with the ICMR in Type 17 study showing, again, more than 101 million projected patients of diabetes in India, more than 136 million pre-diabetes in India. And we also all know from our clinical practices that we have a clustering of risk factors, right, due to which patients here in India tend to develop vascular disease, coronary vascular disease and coronary events at least a decade before their Caucasian brethren. Not wasting too much time, we will actually delve into each of these aspects of diabetes and what is to follow and what can be offered to patients to empower us in our clinical practice. To shed more light on the same, we have some of the best in the country today to educate all of us going ahead. I have the honor of introducing both our speakers for the day. For the first, we have none other than Professor Dr. Ganapathi Bantwal himself, who's the professor and head of the Department of Endocrinology at St. John's Medical College, Bangalore. Sir was also the immediate past president of the Endocrine Society of India, the vice president of the Karnataka Endocrine Society, past treasurer of, again, the same Karnataka Endocrine Society, and also with multiple other bodies. He's also received numerous awards across his stellar career and has also published more than 100 papers in peer-reviewed index journals. He's also been a principal investigator for more than 80 clinical trials. We also have, as our next speaker, Professor Dr. Sameer Aggarwal, who's head of the Department of Endocrinology and Metabolism at Apex Plus Super Speciality Hospital, Rohtak, India. Sir again was awarded, has been awarded numerous accolades throughout his illustrious career. He's edited books, the Insulin Manual 2020, also a clinical manual on SGLT2 inhibitors, and has also been a section editor for SADICODE International Textbook of Diabetes. On the same note, I hand over to our first speaker for the day, Professor Bantwal, sir, over to you.
Yes, thank you, Dr. Parthasarathi. Thank you, Doc Mode Technologies, for the opportunity. I'll be talking on what happened in the EASD on obesity. As you know, obesity is not a cosmetic problem. It's a killer that can reduce life expectancy through numerous comorbidities. So this was told by Matthias Bloer from the University Leipzig, Germany, EASD 2023, Hamburg. So you must be knowing that there is a difference between Asian Indians versus the Westerners in terms of development of diabetes and all. Diabetes risk pathways vary between Asian Indians and white Europeans with a significant emphasis on obesity. Asian Indians have an elevated risk of type 2 diabetes due to genetically influenced lower beta cell function and lipodystrophy, resulting in earlier diabetes onset compared to white Europeans. So you must be knowing that we get diabetes, we used to tell a decade earlier. Now I can tell that it's not 1 decade, it's probably even 2 decades earlier. We are not, in Asians, we are thin fat Indians. Our BMI is normal and we have more visceral adiposity. That is a bad fat, and that is the reason we are more prone to develop. Similarly, the obesity, we say when our BMI is more than 25, overweight when the BMI is between 23 to 24.9. So that's because these dyslipidemia, or for that matter, diabetes, etc., all start increasing at a BMI of 23 itself, compared to the Europeans or the Caucasians, where it starts happening after 25. So this BMI cutoff of 23, 25, and all are arbitrary numbers when the morbidity starts increasing. So that is how it is. And that is the reason now the term obesity is also being replaced by a new terminology, that is adiposity-based chronic disease, because if we just tell obesity, people are, I mean, a chubby child, we are all happy. So it's similar to that. You have a paunch, that means you're doing well. That's how it is. So it's not so. So it's not a good thing also. So that's a reason to know the impact. Obesity is not good. The terminology is, new terminology is ABCD, that is adiposity-based chronic disease. Is obesity increasing in India? So the prevalence is around 135 million. We stand 99th rank out of a total of 183 countries. And we are the third largest after USA and China in obesity. This is a WHO report. So EASD, some things on obesity and pre-diabetes. So if you see here, the trends in drugs for diabetes and obesity, a survey done from 2004 to 2021 in Norway. So what they found here was obesity is a major and growing public health problem. Safety concerns restrict the use of anti-obesity agent. You must be knowing we had a lot of anti-obesity agents like sibutramine. It went after that STORM study where they found there was an increased cardiovascular risk. Lorcaserin was available from India. It just went off because increased risk of cancers. Then we had the endocannabinoid receptor agonist. They also went off because of the increased suicidal tendencies. So a lot of drugs have gone off. So right now we have drugs like orlistat, a very weak drug. We have liraglutide alone, but then liraglutide is available for anti-obesity agent as the name Saxenda. So that's available. Similarly, we have dulaglutide for diabetes, the Trulicity. But then you get a 3 milligram ones, which is used for obesity actually. So that's not available in India. Similarly, semaglutide injectable is available in the West, but not available here. So the new dosages include up to 2.4 milligrams per week. So that's available. So not still available in India. So we had safety concerns for those drugs. Here, not much of a thing. So this was a registry-based cohort study in Norway. In 2021, bupropion naltrexone was the most commonly prescribed anti-obesity drug. Predominantly to women, 74% they were using it, while liraglutide and semaglutide were also used, which are all GLP-1 agonists. What they found was there was a significant rise in anti-obesity drug use, especially in middle-aged women. And then they say it could have a possible impact on diabetes incidence and prevalence due to the use of glucose-lowering medications for weight reduction. So these drugs help not only in combating obesity, but also helps in reducing hyperglycemia. So for that matter, diabetes. As you know, obesity leads to type 2 diabetes. So after the age of 18, if you gain weight of around 5 to 10 kgs, you have a 5 to 7-fold increased risk of obesity. So the conclusion from this Norway registry was the use of anti-obesity drugs has experienced a significant recent increase with a notable uptick in middle-aged women. Glucose-lowering medications for weight reductions carries implications for future incidence and prevalence of diabetes. Then they looked into effect of early versus late time-restricted eating on inter-day glycemic variability measured by CGM in adults at type 2 diabetes risk. So it was they recruited 8 sedentary individuals, 52 years, BMI of 29, A1C was 6%, habitual food intake more than 14 hours per day, CGM measured by MAGE, CV, so mean average glucose confidence, the coefficient of variation and mean amplitude of glycemic excursion. So the MAGE reduced by 0.9 millimole per, there is a mean average glucose reduced by 0.9 millimoles, roughly around maybe 16 milligrams. The coefficient of variation reduced by around 3%, and the MAGE reduced by around 0.4 millimoles. So this was a randomized crossover study. There were 2 groups: early time-restricted eating versus late time-restricted eating. And then the other group was unrestricted versus time-restricted events. Each phase was 3 days. So this is what the outcome was. So what they concluded here was time-restricted eating showed enhanced inter-day glycemic variability without the need for calorie restriction. suggesting a potential therapeutic approach for individuals at risk of type 2 diabetes. A lot of our patients start asking, sir, can I do intermittent fasting? Yeah, that's nothing but a time-restricted EV. So what here they are concluded, yes, you can do that, and it is useful also. So, but then here they had the pre-diabetic group. So, or categories of increased risk for development of diabetes. So that group was chosen, and they found that the mean average glucose reduced by 0.9, coefficient of variability by 3%, mean amplitude of glucose excursion by around 0.4 millimoles per liter. So you could use in the pre-diabetics this methodology. Obesity and diabetes. Coming to fat deposition and diabetes status hyperglycemia, the link. I told you, you gain weight. Obese individuals have a 7-fold increased risk of developing type 2 diabetes compared to those with a normal BMI. BMI aggregates factors like adipose tissue and lean muscle into a single measure, disregarding the importance of body fat distribution. So here, a study with 351 participants concluded that when you have high visceral adipose tissue and liver fat, more than 10%, were associated with a 4 and 10% increase in diabetic hyperglycemia, whereas increased subcutaneous adipose tissue showed a 2% rise. So many times we see fatty liver. So you must remember that fatty liver or non-alcoholic fatty liver disease, the new terminology is metabolic associated fatty liver disease. This is an independent risk factor for developing diabetes. So another thing is visceral adipose tissue. So you find that patients with pioglitazone, they also tend to put on weight. But then what they do is they produce more of subcutaneous adipose tissue and less of visceral adiposity. And that is how they bring about insulin sensitivity. And also they convert the large adipocytes into smaller adipocytes, which are more insulin sensitive. So that is the reason we say we are increasing the weight, but still you are reducing the insulin resistance and improving insulin sensitivity is via this. We can also call this as the fatty acid steal mechanism. So accumulating fat in various locations increase the likelihood of diabetes hyperglycemia. So this was a simplified Bayesian network model. So what they say is you have elevated visceral adiposity, elevated liver fat, so that increase the risk of development of diabetes. 4% for visceral adiposity and 10% for elevated liver fat. But if you only have subcutaneous adipose tissue, it was just 2%. Another study, normal weight visceral adipose obesity in type 2 diabetes patients carries a higher 10-year ASCVD risk than overweight or the obese individuals. A Chinese study. So individuals with, what they concluded here was individuals with visceral adiposity have an increased atherosclerotic cardiovascular disease, naturally so. So because more visceral adiposity, more inflammation, more nuclear factor kappa B, the more insulin resistance, the more, if the moment you have more insulin resistance, we are actually activating the MAP kinase pathway, which is the atherogenic producing pathway. So that is the reason you get higher ASCVD risk. Coming to novel strategies on obesity management, ghrelin, growth hormone secretory receptor, and the LEAP2, that is liver expressed antibacterial peptide 2 in obesity and type 2 diabetes. So the ligand ghrelin binds to the growth hormone secretory receptor, and what it does, stimulates energy intake, increases body weight, and increases blood glucose levels. So the thing is, if you have a ghrelin antagonist, it will produce a converse. Similarly, LEAP2. So LEAP2 is the liver expressed antibacterial protein or a peptide 2. This is an endogenous antagonist of the ghrelin receptor, secretory receptor, GHSR. So what it does is it inhibits appetite and produces weight loss. So this could be the potential target for new anti-obesity and anti-diabetic drug strategies. So if you get it in the form of a tablet, it will be the greatest thing. So because nowadays we have a majority of the medications which are in the form of injectables, but if this comes in the form of a tablet, it will be very useful. That's number one. Secondly, we have the GLP-1 receptor agonist. Now we have the twin cretins, that is a tirzepatide, which is a GLP and a GIP receptor agonist. And now you have the 3Gs also having the glucagon agonist, you can say. So tricretins, we call it as. So they are also there, and they are supposed to produce a lot of weight loss, But then they act at the level of the brain to produce early satiety and all. So ghrelin is the immediate one. Intake itself comes down to begin with itself because it's blocking the first pathway. A novel potential therapeutic target in metabolic disease, role of ghrelin, GHSR, and LEAP2 in type 2 diabetes in obesity, once again from China. So continuous administration of LEAP2 reduces body weight, improves glucose tolerance, and reduces subcutaneous adipose tissue accumulation, and also leads to correction of insulin resistance. So it improves metabolic damage and a direct regulatory impact on islet cell function. So something about the dapagliflozin. So as you know, dapagliflozin can also help in reducing obesity. People taking dapagliflozin lose around 3 to 4 kgs average weight loss. And the predominant, it's fat loss. By NMR studies, they have found that it's fat loss. So it mitigates heart failure outcomes in obesity and diabetes. It counteracts the pro-apoptotic effects of secretome of adipose cells from obese subjects in human cardiac progenitor cells via the SGLT co-transporter. So dapagliflozin prevents the human cardiac progenitor cell damage through an SGLT2 dependent mechanism. So dapagliflozin preserves the cardiac myocyte function. It sees that it survives for a longer time via this method. So we know that dapagliflozin is one of the, the decade of the molecule. We did trials with all the three gliflozins, canagliflozin, dapa, and empagliflozin. When it first came, we were really worried, will it do a real good job? Because it was catabolic in nature, because you're losing glucose in the urine, but then it has, we are getting every time phenomenal results. So telling that it's a great drug, and here you can see it is preventing the cardiac progenitor cell damage through an SGLT2 dependent mechanism. SGLT2 inhibitor dapagliflozin enhances skeletal muscle fatty acid uptake in subjects with type 2 diabetes. A PET study, a positron emission tomography study. So here what they did was 53 subjects with poorly controlled type 2 diabetes. They were assigned to either a daily 10 milligram dose of dapagliflozin or a placebo for 6 weeks. More than 50% were male. Average age was 65 years, a BMI of 30 kg per meter square body surface area, and an A1C of 6.6. So they used this FTHA, so 18-fluoro. So FTHA, that is fluoro-6-thioheptadecanoic acid. It's used as a tracer of free fatty acid uptake and oxidation in myocardium and skeletal muscle. So you can see the treatment outcomes at 6 weeks. A1C reduced by 0.2%. BMI decreased by around 0.5 kg per meter square body surface area. Fatty acid uptake increased in the skeletal muscle. In the brain, it increased by 32%. In the small intestine by around 0.5%. That was not statistically significant. And then serum free fatty acid levels during the scans not significantly increased. And then serum hydroxybutyrate level increased by around 0.04. And the fasting plasma glucose decreased by 0.62 millimoles. So coming to the anti-inflammatory and antioxidant effects of SGLT2 inhibitors in epicardial adipose tissue of subjects with severe heart failure. So SGLT2 inhibitors exert cardioprotective effects in patients with severe heart failure through mechanism involving reduced inflammation, improved mitochondrial health, decreased oxidative stress in epicardial adipose tissue. So in fact, in the trials of the EMPA-REG and other trials, you find that the benefits of the dapagliflozin, for that matter, happened as early as 17 days, on the 17th day itself. So these gliflozins are the #1 drugs for hospital to reduce the hospitalization for heart failure, where it reduced to the tune of 40%. Okay, this was the twin creatine. So here you see that SURPASS-2 trial showed that tirzepatide treatment across all the doses, 5 milligram, 10 milligram, 15 milligram, led to longer continuous periods with an A1C less than 6.5% and weight loss of more than 5%. So here they compared tirzepatide with semaglutide. So an exploratory analysis of the SURPASS-2 trial. So in fact, in this trial, so tirzepatide is a twin creatine, a GLP and a GIP, versus semaglutide, which is an injectable, which is used once a week. They compared it with, I think, with the 2.4 milligrams. So you can see that tirzepatide, more number of patients could achieve an A1C less than 6.5, and more number of patients could achieve a weight loss of more than 5%. In fact, there are many people who could get even more than 20% weight reduction with this, similar to that of what you get with the bariatric surgery. So with the sleeve gastric resection, you get around 22%, and with the Roux-en-Y, it's around 27%. So almost to the tune of 20% they have got in some of the patients. Coming to exercise for obesity and diabetes. So you have a type of exercise known as HIIT, that is high intensity interval training. So here they looked into the effect of insulin sensitizing high intensity interval training on selected exokines and adipokines in obesity and type 2 diabetic patients, study from Denmark. So middle-aged type 2 diabetes, obese and lean men underwent an 8-week supervised high-intensity interval training program consisting of 3 weekly sessions of rowing and cycling. Prior to the HIIT, individuals with type 2 diabetes had notably higher plasma FGF21 levels, while obese men with and without diabetes had significantly elevated plasma leptin levels in compared to lean individuals. Naturally, leptin is a marker of visceral adipose tissue. More fat, you have more leptin levels. And as you know, obesity is a leptin-resistant state. Similarly, FGF21 is also a resistant state. Obesity is a FGF21 resistant state. It's a key mediator of free fatty acid and lipid metabolism. So, in fact, FGF21, via increased expenditure, can activate the sympathetic nervous system and can produce browning or beiging of the white adipose tissue. So here you can see men with type 2 diabetes, what happened to during this HIIT 3 weeks trial. Plasma leptin level reduced by 16 to 25% in obese men with and without diabetes, which is significant. It did correlate with leptin reduction. So there was a reduction in fat mass and that came down. Serum adiponeptin levels decreased by 19 to 18% in all groups. Correlation with adiponectin reduction, it was inversely correlated with increased insulin sensitivity. FGF21 levels decreased by 28% in the obese glucose tolerant. Then you had what is known as the GDF15 level increased by 16% in men with type 2 diabetes. IL-6 and angpetal-4 levels, no changes observed. And the group differences in response to HIIT, no significant group difference in response to HIIT. So GDF15 is a stress-regulated hormone that signals exclusively via the GFRAL RET heterodimer. So this GFRAL expression is restricted to the area postrema and the nucleus of the tractus solitarius, and via this it suppresses appetite. So to conclude, obesity is a key factor for development of type 2 diabetes. It is strongly tied to insulin resistance, and obesity is a chronic inflammatory state. Obesity-related alteration in glucose balance highlight the robust link between obesity and type 2 diabetes. Weight loss directly enhances glycemic control in type 2 diabetic patients via clinical or nutritional methods. Thank you for patient hearing.
Thank you, sir, for that wonderful talk. We now hand over to Dr. Aggarwal for his session. Dr. Aggarwal, over to you, sir.
Thank you, Parthasatriji, and thanks to DocMood for arranging a good academic event. It's a privilege to be co-speaker with Dr. Ganapathi, and thanks to audience who have taken time, especially these interesting cricket matches going on. So uh, I think we had a very nice presentation, and my job is to talk about SGLT2 inhibitors and kidney disease. So as Dr. Ganpati was telling that there has been recent updates not only with obesity but also with regards to SGLT2 inhibitors and their role in diabetic kidney disease. We know that type 2 diabetic patients are at risk for development of renal dysfunction, and there can be many reasons for it. It can be hypertension accompanying diabetes, it can be the oxidative stress accompanying diabetes, vascular disease accompanying diabetes. So, diabetic kidney disease is a frequent uh, thing which happens in type 2 diabetes and longer duration of sometimes type 1 diabetic patients also. And diabetic kidney disease seems to be the foremost cause for the end stage renal disease. So, key priority in management of diabetes is prevention of kidney disease, and I think it will be very good if we can prevent the development of microalbuminuria. And we know that once the urine albumin excretion goes more than 300 microgram per gram, then it's difficult to go back. And patients of type 2 diabetes experiencing a rapid decline in their EGFR, this decline typically leads to end stage renal disease. Early prediction of declining renal function is important so that we can hit on those things. And so we always talk about parameters which can show us that the type 2 diabetic patient is developing a renal dysfunction. Conventionally, we talk about EGFR and a spot urine microalbumin creatinine ratio or a 24 hours urine albumin excretion. So any type 2 diabetic patient who is showing albuminuria or showing a decreased GFR that is less than 60, it implies a diabetic kidney disease. Any recent decrease in eGFR, rapid decline in GFR, there is observation of some red blood cells in the urine, sudden increase in the creatinine. I think there can be some non-diabetic causes also for the kidney disease in these group of type 2 diabetic patients. Is nephropathy a leading cause of end-stage renal disease in South Asian patients, or are the South Asian patients are at increased risk as compared to Caucasians? There has been the data, particularly if we talk about the results from this Hague diabetes study. Yes, South Asian people showed a significant higher risk than the native Dutch. This study was published a couple of years back, and diabetic nephropathy was the leading cause of end-stage renal disease. The data was there from around 3,800 type 2 diabetic patients, and around 1,300 South Asian patients were there in this group. And patients who received treatment from 2006 to 2017 were studied. And this study showed that yes, South Asians are at increased risk for nephropathy also. So conventionally, we are doing a multifactorial approach in management of type 2 diabetes where we can prevent the onset of nephropathy. We are taking care of blood glucose, we are taking care for the blood pressure, we are putting HbA1c at right targets, we are asking patients to decrease their weight, we are hitting at their lifestyle parameters, and we have been using ACE inhibitors or angiotensin receptor blockers, that is called as RAS blockade. But now seeing the benefit of SGLT2 inhibitors, particularly with these randomized controlled trials like DAPA-CKD, CREDENCE, and EMPA-CKD trial. The latest KDIGO guidelines also recommend that SGLT2 inhibitors should be used early on in management of type 2 diabetes and CKD. Of course, you can use it alone or in association with metformin. And seeing the benefits of these randomized controlled trials, even the CDSCO DCGI Indian guidelines also say that you can use SGLT2 inhibitor as with GFR as low as 25 ml, even in patients of CKD who are not diabetic. So the benefits of SGLT2 inhibitors in non-diabetic population has also been seen equivalent to as compared to type 2 diabetes and CKD. So yes, we have been talking about that SGLT2 inhibitors, they cause natriuresis, they improve the tubuloglomerular feedback, that we call it as TGF feedback. But what's there in 2023, especially with the recently concluded EASD in Germany? So this was an interesting randomized controlled trial which used PET imaging, and we have very few studies who talk about these imaging studies, uh, talking about the type 2 diabetes oxygen consumption in the kidneys. So this was a study which evaluated SGLT2 inhibitors. It was a randomized controlled trial using C11 acetate positron emission tomography based imaging study. Since kidney hypoxia has been proposed as the key pathophysiological mechanism in the development of chronic kidney disease, uh, potentially stemming from a mismatch between oxygen delivery and oxygen consumption. And SGLT2 inhibitors are since proved to be a kidney protective agents. So this was hypothesized that SGLT2 inhibitors will lower the kidney oxygen consumption by reducing GFR and by reducing the tubular workload also. So of course it was a sort of a limited number of patients were studied in this randomized controlled trial, 20 adults with type 2 diabetes who received a 4-week treatment with SGLT2 inhibitor, ertugliflozin, and matched placebo in RCT. Patients were treated with metformin and received maximal tolerable dose of ARBs, and whole kidney oxygen consumption was studied using PET imaging, and GFR was measured using the iohexol clearance, and tubular sodium transport, kidney oxygen consumption, kidney sodium loads, various parameters were studied. So it was a sort of a unique study. I do not think we have such data except for this study. And we can see that the kidney sodium load, tubular sodium load was less in the SGLT2 group. So implying that use of SGLT2 inhibitors lowers tubular sodium load, kidney oxygen consumption, potentially decreasing hypoxia. Uh, so I think additional data with regards to effects on cortex and medulla specific oxygen consumption and kidney MRI data that also will be presented. But I think this is the encouraging data we have from this randomized controlled trial. Again, one of the novel molecules, CBIR antagonists. So these this was again one of the presentations done at EASD, where additive effects of SGLT2 inhibitors and CBIR antagonism was studied in diabetic nephropathy. It was studied if combining CBIR antagonists with SGLT2 inhibitors, they are offering superior kidney protection compared to either treatment alone. And in fact, combination of SGLT2 inhibitor and this molecule INV202 it was significantly more effective than either treatment alone. And in fact, pre-presentation of this data, we had CBIR antagonist data in animal studies and in rats also. Again, an interesting study, RCT, where renal effects of empagliflozin alone or in combination with semaglutide in albuminuric type 2 diabetic patients. And we have majority of the guidelines recommending use of GLP agonist ahead to other anti-diabetic agents, seeing the cardiovascular benefits of GLP agonists also. So it would be interesting what happens if we can combine these two drugs. It was a randomized double-blind control study with type 2 diabetic patients having albuminuria. Patients first received around 6 months of empagliflozin followed by a 26-week randomized treatment with subcutaneous semaglutide or placebo. It was an open label design. The study for the first 26, it was the open label EMPA, and the study assessed the primary and secondary outcomes, including urinary albumin creatinine ratios change, body weight change, GFR, and blood pressure. Interestingly, we didn't have much of the reduction in, if we talk about the urinary albumin creatinine ratio. um, the combination group, of course, numerically had more reduction, but not significant. We didn't have significant GFR change also. So, in fact, I think we need to have more and more data with regards to this. These patients were on empagliflozin, and to the top of that, semaglutide was added. So the duration of diabetes, number of patients which have been studied. So I think we need to have more and more data. But whatever data we have with this study, it shows no significant difference in the primary endpoints like urinary albumin creatinine ratio between the combined treatment group as compared to EMPA alone after around 6 months. So comparison of the combined use of GLP agonist and SGLT2 inhibitors with other dual second line therapies. Again, we have good paper presentation, benefits of dual therapy on renal outcome in type 2 diabetes. Around 87,000 patients were studied, and the study period was around 10 years from 2010 to 2021, and outcomes which were studied was chronic renal disease, end-stage renal disease, and greater than 50% eGFR decline from the baseline. Initiation of dual second-line treatment for management of type 2 diabetes. This data showed that dual therapy with GLP-1 agonist and SGLT2 inhibitors showed greater reduction of these primary outcomes. So what are the clinical observations to improve the prediction and progression of diabetic kidney disease? There has been machine learning models for predicting worsening renal functions using 1-year time series data of urinary protein and eGFR in patients with type 2 diabetes. So this was again presented at EASD. Variable components of urinary protein and GFR in prognosis predicted improved accuracy compared to models using fixed time evaluation. So I think interesting, unique data with this presentation. And there is again one of the markers for chronic kidney disease, hemoglobin glycation index HGI. Is it a novel risk factor for incident chronic disease? This study showed that HGI or hemoglobin glycation index was significantly and positively associated with presence of CKD, and HGI was a robust risk factor for CKD with multi-adjusted hazard ratio of 1.2. So do we need new pillars of therapy for renal protection, particularly those patients who have a rapid decline in GFR? So this was the, again, presentation, need for newer pillars of therapy for renal protection, pronounced eGFR slope improvement by SGLT2 inhibitors and GLP agonist in people with rapid eGFR decline, 75 individuals with type 2 diabetes and advanced CKD stages 3 to 4 treated with SGLT2 inhibitors. Individual eGFR trajectories were tracked, and GLP agonists were initially or additionally prescribed in around 50% of these patients. Combining GLP with SGLT2 inhibitors seems to be a promising approach since this GFR decline improved, the slopes improved in patients who were put on SGLT2 inhibitors and GLP agonists. We have been talking about prediction of kidney disease progression. We have been using eGFR, microalbumin creatinine ratio, but improving the diagnosis and prediction of kidney disease protection. There is a lot of talk about serum cystatin C. It seems to be a conventional superior to conventional serum creatinine based EGFR in determining 10-year mortality risk in community based people with type 2 diabetes. Another marker is NADPH oxidase NOx5. It also is being recognized as a significant source of reactive oxygen species, which can be detrimental for the renal tissue and can play a crucial role in diabetic kidney disease. So we can have treatment inhibiting NOx5, which can improve the kidney outcomes. So these are the two markers which are being talked about. So to conclude, diabetic kidney disease is definitely one of the significant cause of end-stage renal disease. We have limited therapies in management of type 2 diabetes and CKD. Early prediction of declining renal function is of great importance since if we intervene early, we can prevent the onset of nephropathy and also we can decrease the progression of nephropathy. Patients with type 2 diabetes and CKD have high rates of adverse events and mortality as compared to type 2 diabetic patients who are not having CKD. With interesting data presented at EASD, we have been talking about the new therapeutic areas. We can touch on those pathophysiological mechanisms that how SGLT2 inhibitors are improving kidney outcomes. SGLT2 inhibitors are decreasing the tubular sodium load, kidney oxygen consumption, and mitigating the risk of hypoxia. So establishing the robust efficacy and confidence in use of type 2 diabetes and CKD and also in non-diabetic CKD patients. And SGLT2 inhibitors in conjunction with GLP, I think we need to have more data where we can convincingly say that it can prevent the progression of nephropathy. But definitely both of these drugs when combined can be good for weight management also and can be useful with limited data which has been presented in EASD in those subgroup of patients who have shown a rapid eGFR decline. So thank you all for your patient hearing.
Thank you so much, dear sir, for your wonderful talk. And we are very sure the audience which has heard definitely have takeaways from the same. We do have a few audience questions, which we would like to take at this point of time. The first question to Professor Bandwal, sir. Sir, Dr. Praveen asks, sir, when should we initiate pharmacotherapy for obesity? Should it just be based on BMI or should it be based on associated comorbidities? Over to you, sir.
So I think when you have an associated comorbidities, then the BMI cutoff levels actually comes down. For example, I'll just give an example for, say, bariatric surgery. We say if it is more than 35 BMI, then you start it. But if you have type 2 diabetes with comorbidities, then you bring it down furthermore. And if it is an Indian or an Asian, we still bring it down furthermore. So it depends on the comorbidities also, and it also depends on the BMI value also. Now coming to the medical therapies. Now, for example, if you're using a semaglutide or for that matter, liraglutide, we can use it at a lesser BMI also. Say, for example, liraglutide helps in CV protection. You have seen the ADA EASD guidelines, what it says. If you have any patient with ASCVD risk, then you can actually use this drug for a BMI of 23 also because you're getting the cardiovascular benefit. So it could be used for that also. So these drugs, see now liraglutide is available up to 1.8 milligram. But if you're using only for obesity, which is not available, then you get what is known as Saxenda, which is a 3 milligram one. And that's used actually, it's a higher dose. So that's used only for obesity. But the ones what we have in India, we actually use it at a lesser comorbidities also, at a lesser BMI also. Even with normal BMI, you have an ASCVD risk, you could still use it.
Thank you so much for that, sir. So the next question to Dr. Aggarwal. So Dr. Farida asks, so what precautions should you take while administering SGLT2 inhibitors in non-diabetic CKD patients? And up to what EGFR can we practically give in patients with CKD?
So non-diabetic CKD patients, SGLT2 inhibitors, if the patients are already on loop diuretics, they can cause some postural dizziness. That can be one of the issues. And we can give up to EGFR up to 25, I think, with the DAPA CKD trial. I think the GFR has been lowered now. So that should not be an issue with these drugs if we are talking about the renoprotective benefits. So otherwise, I think we should be careful with regards to use of SGLT2 inhibitors. We should be aware of the adverse events with these drugs, and like mycotic infections are quite common. You can have like euglycemic decay in type 2 diabetic patients, and patients with significant peripheral vascular disease. Sometimes we are cautious using these drugs. They can have an initial decline in EGFR, and that we should be careful about that aspect also. Initially, they can cause some sort of hyperkalemia, so that can be a temporary sort of effect with these drugs. So we have to be aware of these things, which adverse events which can happen with these drugs.
Thank you, sir. So the next question for Dr. Bantwal, sir. So Dr. Siddhi, first thanks you for your detailed didactic talk on obesity. And she also thanks you for discussing on older pharmacological agents like sibutramine, locazepam, and rimonabant. She's also in very short, wonderfully mentioned that you mentioned the reasons why even they got banned. And that now finally we have GLP-1 receptor agonists for the management of obesity. So her take is, so what should we as clinicians bring forth to educate patients as far as taking a prick for the management of obesity is concerned, considering that liraglutide is once daily? So what should physicians do in order to educate patients? Because patients tend to be usually resistant to the idea of a prick, due to which patients do not even take insulin. Your take on the same, sir?
See, number one, you must tell them it is not an insulin. So that's the most important thing. You tell them this is a GLP-1 receptor agonist, and this we are giving for weight reduction and also cardiovascular benefit. The next question they ask is it harmful to my kidneys? You tell no, it has a renoprotective effect. And in fact, it is said to retard the progression of CKD. And in fact, you can use it even to a GFR of 15. So you can use this. So number one, tell it's not insulin. It helps to, if you have a kidney disease, it helps for that. If you have an ASCVD, it helps for that also, based on the leader trial. So you can tell them. So, and also if you're obese, it will help you lose weight also. If you actually tell like this, and they will be convinced. Secondly, you tell them to take at the same time every day, not related to food. The next question they ask is, will I get any low sugars? So you can tell them, no, these are all anti-hyperglycemic agents. They do not produce hypoglycemia. So I think if you tell like this, it should be fine. The only problem we find is the cost. And I think now Indian manufacturers are coming, and I think shortly the cost should come down. I think it will come to around 2,500 from the 6,000 for the 0.6 units. So it's going to come down. So once it comes down, we'll be writing left and right for a lot of them. And once they find the benefit, they'll not only tell themselves, and they'll tell others also. Why are you not taking this medication? It does not produce low glucose. You are going to lose weight, all these things.
Thank you so much for that, those insights, sir. The next question to Dr. Aggarwal. Dr. Aggarwal, Dr. Iyer asks, Dr. Iyer mentions about the agent Finrenone, which is now available in the Indian market. And he mentions that right now, Finrenone is placed in the guidelines for those patients over and above ARBs who cannot benefit with an SGLT2 inhibitor. So from after maximal tolerated dose of ARBs, going next to Finrenone. Dr. Iyer asks, is there a possible future where we might probably see a triple modality therapy where you have maximal tolerated dose of ACE inhibitors, ARBs, followed by an SGLT2 inhibitor, and then Finrenone? So triple blockade or triple benefits with a non-steroidal MRA in these renal disease patients. Your take on the same, sir?
Yes, I think we have been talking about Finrenone since the data was published in NEGM 2020, which showed that after around 2.6 years of the use in patients with CKD and type 2 diabetes, there was the primary event occurred lesser in the Finrenone group as compared to the placebo group. Uh, uh, and this cohort of patients, I think CKD and type 2 diabetes, Finrenone, as was showed in the NEGM study, lower CKD progression and cardiovascular events occurred. I think there was some increased incidence of hyperkalemia in the Finrenone group, which led to sort of slightly more discontinuation in the Finrenone as compared to the placebo. But I think whatever data we have this with the non-steroidal and mineralocorticoid receptor antagonist is definitely reducing albuminuria in short-term trials involving CKD and type 2 diabetes patients. Long-term effects on kidney and CV are still deficient, but yes, encouraging data what we have, especially with this NEGM study of Finrenone.
And so, do you see the benefit of possibly adding it over and above SGLT2 inhibitors in renal disease patients?
I think yes, but we need to have data for this.
So the last question for the day is to Professor Bantwal, sir. So Dr. Anish asks, so when we discuss guidelines, be it for diabetes or even on the management of obesity, should we also focus on NAFLD-NASH? So what are the challenges that exist in these patients and your pearls of wisdom for the same?
Yes, we should look into this. Now, in fact, we have started looking into all the patients with type 2 diabetes. We are looking into NAFLD. So what you can do is you can actually look into the FIPS-4 score. See, you must remember that NAFLD is also a marker of atherosclerotic cardiovascular disease. That means you are at high risk for developing CAD also. So we have started measuring the FIPS-4 score. Just Google, you get this thing. You have to add an EASD value, ALT number, and the platelet count. It will give you a score. So if it is less than 1.43, that means the risk of NAFLD progression is lesser. If you have more than 2.67, then you have more chances. In fact, this patient should be referred to a gastroenterologist. The ones in between, you can actually treat. So what is the treatment of NAFLD is weight reduction. If you only have NAFLD, a 7% weight reduction. If you in addition have NASH, a 10% weight reduction. And if you want to add a medication, the drugs which have been approved are, one is pioglitazone, of course, saraglitazone is also being used. We have found excellent results with this. And of course, the GLP-1 receptor agonist, especially semaglutide, highest reduction, 62% you can say with that. So you actually use these drugs, and we have been actually monitoring. In addition, we are actually doing, when you have values between 1.43 to 2.67, we do a fibroscan. And if the fibroscan shows F1 or F2, we manage ourselves. F3, that is the score is between 8 to 12. More than 12 is significant. It's F3, F4, and we'll have to send them to the gastroenterologist because they may have varices, all those things and all. Between the 8 and 12 is the intermediate group where tell them to you give these medications, repeat the FibroScan after 6 months and see whether there is a improvement in this condition. So you have to look for that. And this is the role of an endocrinologist or diabetologist, and not just leave it alone. It is not the gastroenterologist territory. This is a metabolic associated fatty liver disease. So you should start treating this.
Wonderful, sir. Wonderful. Thank you for those pearls of wisdom. Sir, we've reached the end of our audience Q&A and also of the session. I, Dr. Parthasarathy, take the august opportunity to thank each and every one of you. Special thanks to Professor Bantwal and Professor Aggarwal for their wonderful talks. And we're very sure that the pearls of wisdom that have been taken at the audience end would ultimately empower and enhance their practice. I also would, on a very personal note, want to say this, that the talk was not just a road discussion of trials, but also an implementation of the same into clinical practice, which is something that truly gets appreciated. Dear audience, we also thank each and every one of you, the 1,000+ audience which have joined. We thank each and every one of you for taking your time on a busy weekday to come and empower yourself. And we're very sure that the discussions here have empowered you to better your patient care and its outcomes. Last but not the least, we also thank DocMode for aiding us in the very smooth streaming of this webinar. Thank you so much. Good evening, sirs.